Welcome to the lecture on eating disorders. So, eating is part of everyday life. We know that it's necessary for survival, but it also has a highly social activity component to it, and it's part of many happy occasions. We know that people go out to dinner, we invite friends and families over for meals and celebrations. So, eating is part of our life. Yet for some people, it creates a lot of anxiety and a lot of worry. Are they eating too much? Did they look too fat? Um, so that's what this is going to be about. Our key terms that the book says, you need to know to really understand this content, learn objectives that you should know by the end of this lecture. So when we talk about eating disorders kind of exist on a continuum. We have anorexia, which is going to be eating too little, starvation, and then we have bulimia, which is kind of our chaotic eating patterns, and then obesity, which is excessive eating. There's an overlap between disorders. About 30 to 35% of normal weight bulimic individuals have had a past with anorexia. 50% of anorexic individuals show bulimic behaviors such as purging or excessive exercise. There's some key distinctions. Anorexia is usually an earlier onset, has a below normal body weight, and a overall lack of recognition of the disorder. Bulimia usually has a later onset. They might have a near normal body weight, and they usually have associated feelings of shame and guilt. Prevalence, over 90% of anorexia and bulimia occur in women. It's estimated that 2 to 4% of the US population are affected. Many men, particularly athletes, may suffer but seek treatment less frequently. We have widespread body image dissatisfaction of body image across all gender population. So our categories of eating disorders: anorexia, which is characteristic of self-imposed nutritional restriction, intense fear of weight gain, distorted body image, refusal to acknowledge the disorder, preoccupation with food, meal planning, food-related rituals. We have subtypes within it of restriction, which is weight loss via strict dieting, fasting, excessive exercise, binge purge, where they'll binge eat food followed by purging it, which could be vomiting or laxative use. Behaviors, which are ritualistic eating habits, such as cutting food into small pieces or avoiding eating with others, ignoring hunger, excessive exercise. Bulimia nervosa is characterized by binge eating followed by purging. Purging can be with vomiting, laxatives, or excessive exercise. Eating binges triggered by emotions, and then it's followed by guilt or shame. Clients may have normal weight. With this, you're going to see recurrent vomiting that damages tooth enamel. Sometimes they'll have calluses on their knuckles. Then we have some related disorders, such as binge eating disorder. Binge eating disorder does not have purging or excessive exercise. It's just that excessive eating of calories. It's common in individuals over 35 years of age. This one actually has more higher occurrence in men compared to other eating disorders. It's often associated with childhood overweight issues and weight-related teasing. We have night eating syndrome. Symptoms have morning anorexia, so they're not really hungry when they wake up. They have evening hyperphagia, where they're eating 50% of their calories after dinner, and they also wake up nighttime awakenings to eat. It's usually linked to stress, anxiety, and depression. It's often associated with obesities. SSRIs have been shown to show treatment benefits. Childhood eating disorders. We have pica, where we're eating non-food substances. rumination disorders where they repeatedly regurgitate and rechew their food. And then there's a lot of psychiatric comorbidities with these. Many clients with eating disorders have co-occurring mental health disorders like mood disorders, depression being the most common, anxiety disorders, OCD is frequently seen with anorexia, substance use, bulimia patients may exhibit impulsivity. And then we also have a link to trauma, such as sexual abuse and childhood neglect. Etiology of eating disorders, so biological factors, genetics and family history. Eating disorders tend to run in families, possibly due to inherited personality trait or psychiatric vulnerabilities. We can have hypothalamus dysfunction, where lateral hypothalamus dysfunction reduces eating and it provides a lower response to food stimuli. Ventromedial hypothalamus dysfunction results in overeating, weight gain, and impaired satiety response that we see in clients with bulimia. Neurochemical factors, low norepinephrine reduces metabolism and lowers the blood pressures in the anorexic patient. Low serotonin is seen in increased binge eating behavior. SSRIs improve bulimia symptoms, suggests that serotonin imbalance could be related. When we talk about developmental factors, we have adolescent struggles. Pressures to develop autonomy and identity can be difficult in controlling, especially in a very enmeshed family. So, dieting and weight control may be a way for them to exert that autonomy and identity. Risk factors, body dissatisfaction, if they have increased risk of binge eating, low self esteem, stress, and depression. Signs of developing an eating disorder, eating in secret, food preoccupation, and extreme guilt and shame. And then body image distortion. So, anorexia, they have extreme body dissatisfaction despite severe weight loss. Bulimia usually has feelings of overweight or undesirable even at a normal rate. We look at our family influences. So we have dysfunctional family dynamics sometimes, a lot of family conflict, lack of emotional support, sometimes abuse, sometimes neglect. Parental over control or an emotional neglect has been noted to increase the likelihood of eating disorders, with eating being a source of a coping mechanism. And then sociocultural factors. So media influence, right? Thinness is associated with beauty, success, and happiness. The dieting industry profits from promoting unrealistic body standards. We have our social pressures, such as sports performance pressure. So our ballets, our gymnasts, our wrestlers all emphasize body form, which can contribute to eating disorders. Bullying and peer teasing, social media and cyberbullying, and then recent positive trends that we've seen have helped with body diversity in advertising and the media. Cultural considerations. So, these are more common in our developed nations: US, Canada, Europe, Australia, Japan, New Zealand, South Africa. Westernization and beauty standards that society emphasizes thinness and beauty. We also have a greater abundance of high fat, high carb diets contributing to the eating disorders. Um, Food, culture, and our social influences all are deeply rooted. Um, Eating is, celebrations, family gatherings, traditions, a lot of stuff revolves around food. Cultural attitudes towards food and body image are different in other areas of the world, which impact the identification, experiments, and treatment of food, as well as with eating disorders. So, understanding those influences is really crucial for understanding effective treatment. So now we're going to go specifically on to anorexia. So anorexia's onset is typically between ages 14 to 18. Usually we're going to have a deny of negative body image concerns. They'll take pride in their weight control. They'll struggle to identify emotions related to life events, and they may experience a profound sense of emptiness. As it progresses, we usually see some depression and some mood instability that becomes more evident. We have increasing dieting and compulsion, which leads to a lot of social isolation. As I said, eating is very much a social structure. So if your friends are going out and you don't want to eat in public, you kind of start to have that social isolation. They also might start to develop some mistrust and some paranoia. They may believe that peers are jealous of their weight loss. They may say that family and doctors are trying to make them fat and ugly. Recovery and mortality rates, 30 to 50% achieve full recovery, 10 to 20% remain chronically ill. Risk of death is 6 times higher than in general population. The lowest body weight and the longest illness duration have the highest relapse rates. And then they also have associated abuse of laxatives, which will increase medical complications that puts them at further risk for death. Um, Usually, death is related to medical complications or suicide. Our treatment and prognosis, it's very challenging to treat. Clients are usually often very resistant. They deny their problems, and they're very much uninterested. Levels of care, we can do inpatient units, partial hospitalizations, and outpatient therapies. Hospitalization becomes necessary when we have severe weight loss resulting in cardiac issues, fluid and electrolyte imbalances, as well as if we have risk for suicide. We also want to use some cognitive behavioral therapies with these guys to help prevent relapse and improve outcomes. So again, with the management, a little bit more in depth on that. The primary goal is weight restoration, nutritional rehabilitation, rehydration, and correct any electrolyte imbalance. Um, for nutritional approach, we want balanced meals and snacks, and you want to do a gradual increase in caloric intake. They cannot go from, 10 calories a day to 2,000 calories a day. It needs to go slowly. Severe cases may require TPN, tube feedings, and hyperalimentation. These guys should have supervision in the bathroom to prevent them from purging during feeding. Effective measures, we note if measures with these treatments were effective by they should have weight gain and they should be able to adequately intake their food. For psychopharmacology, really there's no medication that's approved to treat anorexia. They have shown that olanzapine, which is Zyprexa, helps with the bizarre body image distortion, and it also helps. A big side effect of olanzapine Zyprexa is weight gain, so that can help with putting on weight. Um, Medications only effective if the client has enough body weight to them, though. So if their BMI is less than 18, a lot of these medications won't work. Psychotherapy approaches, family therapy is huge. But remember, that if the client's over 18, you have to make sure that you're doing appropriate boundaries. If they don't want the family involved after that, you can't. Um, what family therapy is to do is to kind of help families with um, their kind of enmeshed, unclear boundaries and emotional conflicts that they might be having to kind of untangle things and create clear boundaries and help with those emotional conflicts. And all of that is to prevent relapse. Dysfunctional families may require 2 years of treatment, really, for us to have significant improvement Individual therapies indicated when the family cannot participate, or if the client's older, or if the client's separated from their family. Um, if the client has personal issues needing psychotherapy, we might do family therapy with individual therapy. Overall, with the individual therapy, you want to focus on coping skills, self esteem, self acceptance, interpersonal relationships, and assertiveness. Cognitive behavioral therapy has also been shown if it's targeting multiple factors at once. So we want to be looking at body image disturbance. A lot of times these guys have an underlying need of perfectionism. Um, they have mood intolerance, low self-esteem, and interpersonal difficulties. So when CBT is adapted um, to target those, we have good success. Now we're going to go on to bulimia nervosa. So bulimia nervosa is typically late adolescence to early adulthood, so 18 to 19. We have binge eating. It usually starts during or after dieting. They'll have restrictive eatings, and then between those restrictive eatings, um, like they might try to do like salads only. And then after a day or two of salads, then they'll like really binge. And then that sets them up to do another restrictive eating and then the next binge purge cycle. Clients are usually aware that their behavior is abnormal and they will go through great lengths to hide it. They might have secret food, um, stashes throughout the house, in their cars, multiple fast food stops within a short period of time. Discovery of the disorder is usually found out by family and friends or due to some type of medical complication. Recovery rates: 45% achieve full recovery, 25% have chronic illness, one third of recovered clients relapse. Long-term recovery rates decrease to about 30%. About 3% of overall have death related to complications. So treatment setting for these guys, most are going to be outpatient unless the binging and purging has become uncontrollable or we have a serious medical issue arrive. Unlike anorexia, severe malnutrition is usually less common. So treatment and prognosis for these guys: CBT is great. It's the most effective. It focuses on breaking the cycle of dieting, binging, and purging. It changes their dysfunctional thoughts. We can do in-person CBT. They have smartphone apps for it. And then these guys, we sometimes also use psychopharmacology. So antidepressants have been shown to have some effect. Prozac is FDA approved. And those medications are antidepressants, TCAs, MAOIs, and SSRIs all help to reduce the binge eating, improve the mood, lessen the preoccupation with weight and body shape, and results are often, short term, but they help. Now we're going to be looking at our nursing process for somebody with eating disorder. And the assessment, um, it's going to be extensive, right? And depending on what type of eating disorder will be what you're going to be seeing. So when we're thinking of history, our anorexia nervosa very often is going to be highly intelligent, a perfectionist, um, achievement oriented, eager to please, and approval seeking before they develop the disorder. Parents will frequently report that these were good children causing no problem. In contrast, clients with bulimia also strive to please others and avoid conflict, but usually have a history of impulsive behaviors. So maybe they were shoplifting, maybe they have a little anxiety, maybe a little personality. Our general appearance Anorexia is going to be slow, lethargic, fatigue, emaciated, severe weight loss. We might have loose fitting clothing, lots of layered clothing, especially even if it's hot out, just because they're going to have some thermal regulation issues related to their weight loss. They might be reluctant to answer questions and really have limited eye contact. Whereas our bulimia client is going to be maybe normal weight, maybe overweight. Their general appearance is usually unremarkable. With our mood and affect, clients with eating disorders usually have some labile moods. Um, so with anorexia, we're going to have some sadness, some anxious. They might be really serious. They might be crying. With bulimia, they might appear pleasant and cheerful, but they also might have some expression of intense guilt, shame, and embarrassment. Our thought process, our anorexic client is going to have a distorted body image to the point of delusional thinking, pointing out fat areas on their body that might be severely emaciated. Some develop paranoid ideas, believing that family members and healthcare members are trying to make them fat. Whereas our bulimia client is usually ashamed of their body, but will report feeling out of control and unable to stop their binging and purging. Sensorium and intellect. Most client with eating disorders remain alert and oriented. However, remember with the severely malnutritioned, especially, the anorexic client, might start to have like slower thinking, difficulty concentrating, and a little bit of mild confusion. With our insight and judgment, anorexia lacks insight, has poor judgment. They do not believe they have a problem. Very often they will see their weight control as a personal achievement rather than a health risk. Our bulimian client is going to recognize that their behaviors are abnormal and distressing, but they're really going to report challenges in the ability to control their compulsions and urges. Our self-concept, clients with eating disorders are known to have lower self-esteem. They view themselves solely based on their ability to control their food intake and their weight. They judge themselves harshly, and see thinness as their only measure of worth, really ignoring any other personal achievements. With roles and relationships, that anorexic client will withdraw from relationships. They're going to avoid social events. They may start failing in school despite previous academic success. Our bulimia client usually has this secret life that they live during their binging and purging. So that's all hidden from their family, which may impact their ability to work and have social lives because the amount of time that's consumed by that. When we talk about our physiological and self-care considerations, the severity of the malnutrition of the purging can impact their health. Clients may engage in excessive exercise, pushing themselves to exhaustion. Um, they might have sleep disturbances, dental problems, mouth sores, um, and GI issues. So, with these clients, when we're doing our um, diagnoses, right, your nursing diagnoses, our inadequate nutrition can lead to electrolyte imbalances, cardiovascular complications, and a lot of other issues. So we're going to have, the potential for any of those, as well as self-care or risk for harm. A lot of times when you start to challenge the anorexics eating, they might voice thoughts about wanting to hurt themselves or hurt others, um, ineffective coping, body image disturbance, low self esteem. And then, of course, your outcomes are going to be based on whatever your diagnosis was. So, when we're looking at our nursing actions. Um, Remember, the severity of malnutrition and the purging directly impacts their physical health. Um, so we need to be monitoring their fluids, their electrolytes in the acute stages, lab works. Um, they may require parenteral feedings. You might have to have post-meal supervision where 1 to 2 hours after feeding, don't let them go to the bathroom because they can vomit. We might restrict bathroom time. Um, we want to make sure that when we're doing meal supervisions, that we give them a specific plate of food to eat within a specific amount of time. We want to introduce calories slowly to gradual increase. We want to identify emotional and develop coping strategies. So, help them with accept healthier body image, recognize self-worth is beyond weight, identify non-food related strengths to help broaden their self-perception. Family, client education, really big. We want to teach about basic nutrition and the harmful effects of purging or of restricting eating. We want to encourage realistic eating goals to prevent starvation, as well as that binge cycle that those clients have. We want to involve the family to provide emotional support without focusing on food, calories, and weight. And our overall evaluations, these clients, our anorexic clients, should maintain 5 to 10% of their normal weight without medical complications from starvation or purging. They can have some residual symptoms, but we just need to track their progress. Our community-based care, hospital admission can be required if they have dangerously low weight. So we do, if the BMI is less than 18, they usually have to go into the hospital. A lot of the outpatient centers won't treat them. Once they're below that threshold and we start to reintroduce foods, we have to be concerned about refeeding syndrome, where they can get significant electrolyte imbalances that can cause cardiac dysfunction. They can have bradycardia, they can go into junctional rhythms. They can suffer from cardiomyopathy, um, hepatic complications, renal complications. So depending on, how significant it, their anorexia is, would be if they need that hospital admission. As stated before, bulimia usually doesn't require hospitalization, but we know from nursing school that if we are vomiting frequently, or if we're having frequent stools, that we can lose potassium, and with the loss of potassium, we can have cardiac complications. So it is possible. All of that could give you a hospital admission. Um, and then they also can do partial hospitalizations, which in the area of Knoxville, Tennessee, we really don't have that option where somebody would go somewhere for like hours a day. There are some outpatient therapy groups that they can go to daily. And then, of course, self-help groups are great. For our health promotion, we really want to focus on educating parents, children. One thing that we stress is that it's the parent's job to feed and it's the child's job to eat. We need to help them recognize the idealization of body images in media is unrealistic, help them with developing realistic ideas about their body size and shape. Um, Resisting peer pressure for dieting, improving self-esteem, and coping mechanisms. Self-awareness. So, emotional challenges for nurses. An emaciated client with anorexia can really invoke a strong desire to take care of them and nurse them back to health. However, when the clients reject us, we can feel angry, frustrated, or even incompetent. The client nurse relationship, the client may view you as an enemy because of you are making them eat. They may hide or throw away food. They may become really hostile when they're having the anxiety about eating. A lot of these clients end up being placed on like behavioral precautions for suicide. The nurse should understand the client's behavior is driven by anxiety and fear of gaining weight, and that it's not personal animosity towards them. The nurse's perspective on eating disorders. Nurses may struggle to understand why clients can't eat like everybody else. It could be very difficult to comprehend how a client who's 75 pounds at 5'4" views themselves as fat. Nurses really can wonder why clients have these binge and purges. Overall, it's really important to remember that these eating disorders are a mental illness, just like schizophrenia and bipolar, um, and we need to treat them as such. And that is the end of this lecture.